A very good evening to all of you. So, Wincars is back again, yet with its another academic endeavor. And as we have our academic endeavor coming in soon after our WCC meeting, we have amidst us our very dear members of the core team. We have none other than Professor Dr. Jyotsna Madhuri, our founder, our patron. We have Dr. Sujata, Dr. Sarita, our chairpersons, and our president who are there with us to encourage us with our e-classes, which are our academic endeavor. And in our e-classes, I'm really very glad to have amidst me my coordinators, Dr. Cecily Majela and Dr. Somvya, who have worked hard day in and day out to organize a very interesting meeting of the day. And that is none other than a topic which is really catching up with the recent changes in its management, and it is hypertrophic obstructive cardiomyopathy. And of course, we have an august faculty amidst us, and that is Dr. Cecily Majela and Dr. Nagamani, who are there with us, and they'll be taking you through the trail through. And Soumya is with her marking list always and ever ready to have the students onto the session. So, all off to you, Soumya, to introduce the faculty and start with the case.
Good evening, everybody. Thank you, Shiva ma'am, for such kind words. I know that we actually don't deserve most of them. But today's topic, as Madam had said, is on HOCM. We gave you the topic outright so that we thought that the PGs would study a bit and come. The examiners are Dr. Nagamani. She's a professor of cardiology. She's my teacher from Jayadeva Institute, Bangalore. And the other examiner is none other than Dr. Cecily, who has done a very nice presentations in the last CSI and IC and everything. So the presenter will be a PG called Dr. Abhirami. She'll show us the case and her colleague will show us the ECG, echo and X-ray. Then we can have a discussion on it. And we also have a short topic by Dr. Varun from SWIMS again, based on the recent advances on HCM. Off to you, Dr. Abhirami. We want to start the class so fast because we want to hear to the discussions a lot. Thank you.
Thank you. This is I'm presenting a clinical case of Mr. Enos, a 61-year-old male who is a shopkeeper belonging to modified Kupasamy scale of scale 9, upper lower class. He presented with chief complaints of shortness of breath for 2.5 years. History of presenting illness. 61-year-old male presented with complaints of shortness of breath for 2.5 years. Insidious in onset with the gradual progression from doing his daily chores of moving tools in his shop and difficulty in climbing 2 flights of stairs and walking more than 2 kilometers, belonging to NIHA class 2, to difficulty in doing his personal works like taking 1 flight of stairs and taking bath, belonging to NIHA class 3. Breathlessness was relieved by rest and is not associated with the expectoration, cough, or seasonal variation. This patient's breathlessness was also relieved by taking medications. No history of paroxysmal nocturnal dyspnea or orthopnea. No history of angina, no history of palpitation, no history of syncope or giddiness, no history of swelling of legs, abdominal pain, nausea, or vomiting, no history of decreased urine output, no history of blood in sputum, no history of hoarseness of voice, difficulty in swallowing, no history of prolonged fever, skin lesions, joint pain with swelling, or involuntary movements. Past history. Patient is a known case of systemic hypertension for past 2.5 years. He is also a known case of hypothyroid. He was diagnosed a recent 2 years back, and he is now not on treatment. No history of diabetes mellitus or ischemic heart disease. No history of pulmonary tuberculosis (COPD). No history of surgeries in the past. Personal history. He consumes mixed diet. No history of smoking or alcohol. Normal bowel and bladder habits. Sleep patterns are normal. He is born out of a non-consanguineous marriage. His order of birth is fifth. No other family members have a significant history, and all siblings are doing well. Summary: a 60-year-old male presented with who is a known case of systemic hypertension and hypothyroidism, presented with insidious onset of shortness of breath, progressing from NIHA class 2 to 3 over a period of 2.5 years. Now, clinically, patient is in NIHA class 2 after taking his medications. Differential diagnosis: ischemic heart disease, hypertrophic cardiomyopathy, and valvular heart disease. Ma'am.
Okay, your first option is ischemic heart disease.
Yes, ma'am.
Correct? Why
Yes,
did you
ma'am.
suspect ischemic heart disease in this?
Ma'am, patient is he is a 61-year-old male patient, elderly patient, and he is also having risk factors of systemic hypertension. So my first diagnosis is ischemic heart disease, ma'am.
Is a more common. Does he have any personal habits like smoking or any other precipitating
No,
factors?
no,
Not a smoker.
no, ma'am. He is not. He is not a smoker, and he is not an alcoholic, ma'am.
Second diagnosis is hypertrophic obstructive. Why do you say come to a conclusion from the history itself? It is a hypertrophic obstructive cardiomyopathy. You can very well say it is a cardiomyopathy because without examination, it is not possible to comment about a hypertrophic obstructive cardiomyopathy. So you can
Yes.
very well say it could be a cardiomyopathy. And I think the second diagnosis would be preferably a valvular heart disease. Third would be cardiomyopathies, which is the order of presentation should be the most common, and then the rare one from the history. Once the
Yes, ma'am.
exam is done, that's a different issue. Okay, so
Yes,
that
ma'am.
is very essential. See, and another thing, very good. You have looked into the family tree. That is very important. What are the types of genetic disorders you know? How are they transmitted? It's good you looked into the family tree. Good. So, what are the things you will look for in the family tree? How will be the penetrance?
Ma'am, in case of hypertrophic cardiomyopathy, the penetrance is autosomal dominant type of penetrance. No,
So what
other
does it mean? If a parent has, see, don't fix it to hypertrophic obstructive cardiomyopathy. It's okay because the case is named like that. You tend to fix, but for the exams, students should generally say, okay, whether it's an autosomal dominant, autosomal recessive, or X-linked, how will be the penetrance? How will be if a parent is affected? What is the possibility that the first degree relatives, the children, the first degree relatives, how much will percentage to be affected in an autosomal dominant, in an autosomal recessive, like that you have to answer. Okay, Dr. Abrami? Yeah, you can go along.
yes,
Good.
ma'am.
Tell me. So, okay, it's an autosomal dominant. Then how, if a parent, single parent is affected, what is the possibility? How many percentage the siblings will be affected?
Ma'am, there is a 50% chance of getting disease in the siblings, ma'am. Uh, and if
Very good, excellent. So, if one parent is affected, good. Proceed. Yeah, tell
yes,
me.
ma'am. If it's a recessive kind of disease which is present in both parents, there is 100% chance of the children getting the disease, ma'am. And um, and uh,
If it is an autosomal recessive, leave alone HOCM, the
if
penetrance
it's
generally.
if it's autosomal recessive, there is 100% chances of getting if both parents are affected, and there is 100% risk of getting the disease, ma'am.
I asked for one parent, not both the parents. One
Okay,
parent,
ma'am.
okay, in autosomal dominant,
The
it is
the
50%.
children, there is 50% patient can be becomes a carrier patient.
Okay, so you should know the family tree. And what is the presentation of cardiomyopathy? Like, okay, for example, okay, you're suspecting hypertrophic cardiomyopathy in this patient. What will be the presentation, the age distribution? of HOCM? How will be the presentation?
Ma'am, it can be present from depending on the gene distribution. It can be present from children to elderly age, but that depends on the genetic mutation. And most common presentation is in the between 28 and 32 years.
Very good. It is around the third decade, but these patients have a bimodal age of distribution. That is the word you have to tell. So it is usually in the third decade, but usually these patients have a bimodal age distribution. And that also, it is a very heterogeneous problem. So that depends upon what gene they are getting. That is also very important. So don't fix yourself as it is an abstract. Have you ever seen patients with HOCM getting converted into a dilated cardiomyopathy? Is there a possibility?
Yes, ma'am. There is a
Yes.
possibility.
There is a possibility. Both can coexist also. Now we are having mutations where both patients can coexist. So with the history, without examination, never commit as an obstruction. It may not even be obstructive. Okay. So don't commit like that. You can commit as a
Yes, ma'am.
cardiomyopathy. Okay. And coming to valvular heart
Yes,
diseases.
ma'am.
Yeah, what valvular heart
Yes,
disease
ma'am.
you cannot blindly tell. At 60 years, what is the valvular heart disease which you strongly suspect?
Ma'am, it's mostly of degenerative type of valvular heart disease that is obstructing the outflow. The most probably it could be aortic stenosis type of valvular heart disease, ma'am.
Okay, so which are the valvular heart disease where the patient may present with chest pain?
Uh, Aortic stenosis can present with chest pain, ma'am, and patients
What is
with the mitral stenosis.
mitral stenosis, chest pain? How common it is? What is nocturnal angina? Which condition do you get nocturnal angina?
Nocturnal angina, it's most commonly present in it's present
Any
in aortic.
regurgitation?
Which regurgitation? Ma'am has given a very good this thing. Any other PGs also you can unmute and answer other PGs. Which regurgitation
They
you get
have
nocturnal angina?
actually sent in the chat box, ma'am. Dr. Apurva has
Yeah,
written AS
correct.
with elevated LV-EDP, and Dr. Karthik has written AR. We are changing the chat
Yeah.
settings so that we all can see, ma'am.
Okay. Yes, ma'am. Yes, ma'am. Very
Dr.
good.
Abhirami ma'am, can you please
So,
share your presentation so that
Yes,
we can
yeah,
see
you
it?
can send it to Dr. Kumar. He can, because mine, I think I haven't received it. So you can share it with Dr. Kumar so that everyone will be able to see the clinical findings, ECG, echo, everything.
Yeah, I shared my
yes,
email
ma'am.
ID in the chat box.
Yeah, Dr. Abhirami, I agree with Dr. Cecily, madam. Like, how did you make a diagnosis of HCM at the age of 60? What is the common age of presentation of HOCM? Why it was your second diagnosis? What is the common age of presentation HCM? Which decade do they present?
Just give 2 minutes to the
Ma'am, it's
student.
usually in the third
She has to
decade, ma'am.
share the presentation.
Yeah. Just Dr. Abhirami,
Yeah,
you
please
share
share
it to
it. Please
Dr.
share
Kumar
it.
and then you
Yes,
can
ma'am.
answer. I think by that time, I think we can ask the other postgraduates who are here, ma'am. Dr. Nagamani, ma'am, you can ask them. Fire them with your questions.
They can write in the chat box as well, as she
Nobody
is
has
trying to
answered, ma'am.
share. No, she is already answered third decade. Generally, it is in the second or third decade.
Someone wrote AS and MS. So the same person can tell what is the mechanisms of angina in a case of an MS?
Yes, PGs can write in the chat box. Yes, RV ischemia, good. Cardioembolic, yes, even pulmonary arteries. But pulmonary arteries compressing the coronaries in MS is rare. Where do you expect? In which condition do you expect that pulmonary artery, dilated pulmonary artery compressing the coronary? It's not common in MS. It is in a congenital heart disease. Which congenital heart disease generally? Yes, AST. Correct. It's not common in mitral stenosis. So what are the mechanisms of angina in LVOT obstruction?
Ma'am, it's well, when the demand and supply mismatch, ma'am. A patient is small intramural, small coronary vessels.
Microvascular dysfunction. Yeah, microvascular ischemia.
Microvascular.
Then?
Give me the cause, important cause.
Don't just think of HOCM. I have asked you LVOT obstruction. Say valvar. Yes. Elevated EDPs.
Yes, ma'am.
Associated coronary artery disease. Okay. Sometimes, calcific aortic valve, there can be calcific emboli also to the coronaries.
In the meantime, we can also ask some questions. Dr. Antina is there. And by the time you can ask her something related to the risk stratification or some clinical manifestations so that,
Yeah, sure.
Yeah.
So what is the predominant symptom in HCM, Dr. Abhirami?
Most commonly, it's dyspnea, ma'am. It occurs in
Why
80
do
to
they
90.
develop dyspnea? What is the mechanism of dyspnea?
When patients with most commonly it is due to diastolic dysfunction, ma'am.
Dysfunction, correct. So why do they have diastolic dysfunction?
Due to LV compliance, impaired LV compliance, most commonly due to
They have myocardial hypertrophy with the disarray. So there is diastolic dysfunction, and the commonest symptom would be, as you said, diastolic heart failure symptoms. Correct.
Yes,
so what are the mechanisms of syncope in HCM? In this patient, you said there is no syncope, right?
No, ma'am. This patient, ma'am, the mechanism of syncope is most commonly due to LV or when the patient goes in for any exercise
Somebody wrote it is a fixed LV output. So how is classically the HOCM LVOT obstruction is described as? Is it fixed or?
It's a dynamic obstruction.
Dynamic. Yeah. What do you understand by dynamic LVOTO?
This depends on the loading conditions as well as the contractility of the current muscle.
Correct. It depends on the loading conditions. Yes.
Someone has put as atrial fibrillation, fixed cardiac arrhythmia, atrial fibrillation. So, Dr. Abhirami, in a patient with HOCM, if there is atrial fibrillation, how do they present with? What will be, what to say, will they deteriorate quickly or they will be stable? What is your take on that? Why?
Ma'am, for a patient with LVOT obstruction, this patient can deteriorate quickly, ma'am.
Good. Why?
because ma'am, this they can go in for some they can go in for failure symptoms of heart failure, ma'am, rapidly.
Good. Why? Why?
Um, Patients, because of frequent LVOT obstruction, there is increased LV end diastolic pressure. Patient left atrial size can increase, so patient can go in for acute pulmonary edema. And because reduced cardiac output can be present, resulting in syncope, and patient can also go in for arrhythmias, ma'am.
You're partially correct, Dr. Abhinami. Good. But someone in the chat box, I think Ashish has written that atrial kick will be lost. Very important, and dependent on the atrial kick, that is also very important. So just remember one thing. Normally, the atrial contribution to ventricular output, normally, leave alone HOCM, normally how
Yes,
much
ma'am.
percentage? Atrial contribution to ventricular output. How much does
Atrial contribution,
to
30%.
ventricular output normally? No, that is in HOCM
30,
and aortic stenosis, it increases to 30%, 25 to 30%. But normally it is only just
yes, ma'am.
5%. Okay. So in these
5%, ma'am. Yes, ma'am. Yes, ma'am.
normally it's only 5%. So in HOCM and aortic stenosis, one is dynamic LVOT obstruction, the other one is a fixed LVOT obstruction. In these two conditions, the atrial contribution to ventricular output is nearly 25 to 30%. So in these two conditions alone, if the patients, all patients may deteriorate, but in these two conditions, they'll deteriorate very rapidly. They will immediately precipitate pulmonary edema, cardiac failure symptoms, everything. So it is very important in these two patients that the atrial, they do not develop atrial fibrillation. That is very essential. Okay. So that is the important cause of
Yes, ma'am.
deterioration.
Which other valvular
Yes, ma'am.
condition, the same thing is applicable, whatever Dr. Cecily explained now, where a stable valvular disease with the onset of AF, they become symptomatic and deteriorate.
Yes,
Which
ma'am.
other valvular lesion?
Patient mitral regurgitations, mitral stenosis, ma'am.
Mitral stenosis. Mitral stenosis. Mitral stenosis, it can be mild to moderate mitral stenosis also with the onset of AF and fast ventricular response. You know, it behaves like a severe mitral stenosis.
Yes, ma'am. And
the important causes for
the
syncope in HCM are tachyarrhythmia, ventricular tachycardia.
yes, ma'am.
And Dr. Abhinami, we were mentioning about the genes. What are the common genes that are involved in hypertrophic cardiomyopathy? Could you name some genes that are, because nowadays genetic testing is very essential. It has to be done. So what are the genes you're looking for?
Ma'am, beta myosin heavy chain. It's the most common genetic mutation that most of the patients doesn't have gene, ma'am. If at all they have gene, that this beta myosin heavy chain and myosin binding protein C can myosin binding protein C can be there, ma'am.
What was your first statement? Most of the patients do not have genetic variation. What was that?
Ma'am, it's like we won't
can
be able
genetic
to
or sporadic, but around 60 to 70% have genetic defect, right? It's not
yes,
like 100% have, I mean, it is genetic. There can be sporadic occurrence also, but around 60%, 50 to 60%, they have genetic
Definitely
abnormality.
60% will have a genetic, especially of the myosin binding or the sarcomeric genes can be related to this. So you have to be careful. Among all the genes, as you rightly said, there's myosin binding protein C3 and MYH7 constitute 70%, but 60% are genetically linked. You have to look for the genetic. Okay? Okay.
Dr. Abhirami, I have a question. If there is genetic abnormality in the cardiac troponin gene, how is it different compared to the common varieties like, just now you mentioned myosin heavy chain?
Yes, ma'am. In cardiac troponin I mutation, it favors most commonly the apical type of HCM, and in cardiac troponin T, the risk for sudden cardiac mortality is high, ma'am.
Yeah, they have lesser degree of hypertrophy, but higher risk of arrhythmias. The hypertrophy may not be, that severe, but risk of sudden death is high. Good.
And okay, it's a bit tough question, but any of the PGs can attempt answering this. The current concept, whether it is calcium or potassium or sodium, which electrolyte homeostasis is being altered. Currently, it is being studied, and they found out that this mechanism, this one particular, whether it's sodium, calcium, or potassium, homeostasis is very important in these patients, and it is especially in those patients with diastolic dysfunction. It has been attributed the recent studies. What is the which could you relate to which sodium, potassium, calcium? Anyone? Can you tell me? Recent studies have documented that. Any of the postgraduate? No, dear. It's calcium, very good.
What are the ECG abnormalities do you expect, Abhirami?
For in a patient of HCM, we can have left ventricular hypertrophy. Abnormal Q waves can be present.
Any ECG abnormality which has been linked to risk of sudden death, not validated as such, but then there's some certain ECG abnormalities where risk is supposed to be more. Pseudo-infarction patterns.
Pseudo-infarction, yes.
Is ECG abnormality present in all 100% HCM patients, or few can have normal ECG as well?
We can have normal ECG as well, ma'am.
Yeah. Maybe 5 to 10% of patients, they can have normal ECG. It could be the early HCM also.
Yes, ma'am.
So what are the other markers of sudden death? She's not able to share. We'll keep asking her some questions.
Yes,
Yes. The older ones,
Maybe
probably
we can ask
the new
questions to
additions.
Dr. Antina. She can get some time. The sharing is being done by whom?
I think Dr. Kumar.
Yeah. Okay, right. Please go ahead. Yeah, sorry.
No problem.
Markers of sudden cardiac death. Presence of an arrhythmia, ma'am.
Arrhythmia means what arrhythmia? Non-sustained beating.
Commonly presence of non-sustained ventricular tachycardia, a complete presence of any abnormal AV conductions, ma'am. Any family history of sudden cardiac death.
Yeah, that is the strongest.
Complete heart block.
Family history of SCD.
Okay. Okay.
Anything in echo?
Yes, ma'am. LVOT obstructive gradient more than 50 mmHg.
Okay, severe LVOT obstruction. Okay, any subject to LV thickness?
More than 30 mmHg
Yeah, more than
is more
30.
prone for and
anything else in echo or on cardiac MRI?
Late gadolinium contrast enhancement, which points towards myocardial fibrosis.
Okay.
And
How much it should be
quantification?
to call it
Fibrosis more than?
fibrosis more than 30%.
15%. 15%.
Yes.
Any other marker with respect to cardiac
any other
MRI?
important
Anything in
things?
LV?
Left ventricular ejection fraction less than 50%, ma'am.
Okay, that is in the late stage.
Okay.
Apical
In,
aneurysm, the
HOCM
mid-ventricular
affects
obstruction and an apical aneurysm.
aneurysms. It are the important factors, no? LV apical aneurysms, diagnosing by echo or MRI, these are nowadays considered as an important marker.
Yes, ma'am.
And any fall in BP, huh?
Yes, ma'am.
And when ma'am mentioned about ECG, apart from all these things, any other thing you look for, since you are considering, okay, VT, everything, supraventricular arrhythmias can also occur. So what, okay, to be directly, what PR interval, what specifically you should look for, what type of it is associated with HOCM? PR interval shortening, given the clue.
Yes, ma'am. PR interval shortening. Yeah,
What
it's
syndrome? Which condition you get PR interval shortening with delta waves?
WPW syndrome, ma'am.
Yes, very good. WPW. So HOCM can be associated with WPW. What type of WPW? See, for PGs, two things for your discussion in for exam cases. WPW can be associated with HOCM. Usually it is type A. That is the previous types they described as type A and type B. Type A is there will be a V1. How will it be?
There will be
Very good. I think Dr. Karthik has answered. It will be V1 will be positive in type A, and type B is associated with Epstein's. So it is negative. The delta wave will be negative in V1. Okay, just remember shortly. But you should know the Aruda's algorithm to classify the type of WPW. That is the current algorithm. But previously, it is type A and type B, simplified. Type A in HOCM and type B in Epstein's. So WPW also, you should be aware. Apart from the left ventricular hypertrophy and all those things, you should also look into the PR interval, though it is 5 to 10% only, but still you have to have a look on that, because these patients, when they may develop intermittent WPW or they may develop arrhythmias during exertion. It is all we have already spoken about, that atrial fibrillation. It will be rapidly deteriorating for the patients with such patients. So especially WPW, when they go into AF, it will be a very rapid ventricular response, almost a rate of 200 to 300. With these patients may not tolerate, they may not present with AF. So you should carefully look into the ECG to assess all these things. Okay, Dr. Abhirami?
Yes, ma'am. Yes, ma'am.
Okay. Proceed.
The other, in cardiac MRI, the latest addition is what they call as diffuse fibrosis. In addition to your late gadolinium enhancement and apical aneurysm, diffuse fibrosis also they're looking into that.
Yes, ma'am.
What are the mimics of HCM, Abhirami?
Mimics of athlete's heart, ma'am.
Yeah, athlete's heart. So how do you distinguish? Can you tell us briefly?
It is more often concentric hypertrophy, and it's never more than maximum septal thickness or left ventricular wall thickness is 13 millimeter, and once that regression pattern can be seen in athlete's heart, there is no LVOT gradient present in echo.
What happens to the cavity?
Uh,
The cavity is
cavity,
smaller in HCM. What happens in athlete's heart?
it's enlarges.
LV cavity is bigger.
Bigger.
And what happens to the diastolic function in athlete's heart?
Diastolic function is normal in athlete's heart.
Normal or sort of supernormal. The LV function, athlete's heart, it can be normal or what we call as supernormal. Yes. And once they decondition, it can regress. Sometimes there can be a overlap. So other mimics, somebody, Dr. Karthik has written already. Fabry's, Dannon's, and Pompey's. Yeah, sometimes even LVH associated with hypertension can be confusing. See, your patient, like he's 60-year-old,
Is a known case.
hypertensive?
He is a patient of hypertensive for 200. He is a patient of hypertension. So this can be a differential diagnosis for HOCM.
Yeah.
And
Hypertensive LVH sometimes, if the hypertrophy is not much, so it can be confusing.
Do all patients have asymmetrical septal hypertrophy, or some percentage can have even symmetrical hypertrophy?
5 to 10% of patients can have a symmetrical hypertrophy.
Dr. Kumar, can you project the slides, please?
Ma'am, actually, ma'am sent in different format, ma'am. We are changing the format. So just 2 minutes.
Okay, no problem. Okay, then
Sir,
go on
it's
with
ready, sir. Can I present?
Yes, yes.
My screen is visible?
Yeah. You have started screen sharing. Dr. Abhirami, you can present the clinical details. No.
Excuse me, ma'am. While I'm sharing the screen, please tell me the next. I will change the slide. Okay?
Yes, ma'am.
Just one point I want to add, this Dan and Pompey's, Fabry's, Noon and everything they mentioned about it as a differential diagnosis, but as such, these things are associated with the HOCM. So Dan saying as a differential diagnosis, those things can be associated with the HOCM.
Yes, ma'am.
Abhirami, your patient being 60-year-old, what else you could have thought of? Suppose he doesn't have LVOT obstruction. He has hypertrophy.
Yes, ma'am.
Any infiltrative disorder can we think of? You are looking into the echo, 60-year-old, hypertension. You are seeing some correct, amyloid. Yeah, that you should keep in mind.
Yeah, sorry for the disturbance, but actually we are about to present the slides by Abhirami. Even Dr. Varun is ready with his slides. So the things which have been covered and you think which are not required, you may skip off so that Dr. Varun can also present. He's also ready with his presentation. So we are already 8:17 by the time we could get it. So the points, I leave it to the examiners to have the important points. And whenever you feel appropriate, we can at the earliest invite our guest speaker for his talk also. Sorry for the interruption. Thank you very much.
Maybe we can see the investigations, ma'am.
Yes, ma'am. Ma'am, can you change the slides?
Yeah, quickly go to the summary. Okay. Palpitations. No, sorry, palpation, percussion. Okay. Dr. Abhirami, have you done a dynamic auscultation for this patient?
Yes, ma'am, I have done the dynamic auscultation.
Okay, just tell us about the dynamic auscultation. Differential diagnosis was dynamic LVOT obstruction with a static LVOT obstruction. So how will you differentiate between an aortic stenosis and HOCM? Just tell us that quickly.
Yes, ma'am. In spatting, in dynamic auscultation, Valsalva maneuver, um, the preload decreases, and of aortic in the fixed obstruction like aortic stenosis, the flow also decreases, and hence the murmur decreases, ma'am. Whereas in HOCM, in the strain increases because of increased preload. Sorry, ma'am.
In Valsalva
Because of
and
increase.
yeah, continue, please.
Yes, ma'am. Standing. Yes, ma'am. In Valsalva as well as in standing, preload decreases, ma'am. Preload decreases, and HOCM murmur will increase. Whereas in aortic stenosis, because preload is decreased and fixed obstruction, aortic murmur will also decrease, ma'am.
So Valsalva and standing, what will happen to HOCM murmur and what will happen to AS murmur?
In ma'am, in HOCM, sorry, ma'am, in HOCM, while standing, preload will reduce, ma'am. And LV cavity becomes small, and hence the murmur increases. And
following an ectopic beat, what will happen?
Following an ectopic beat, LVOT gradient increases, and aortic pulse pressure reduces.
Okay.
What do you call that phenomenon as?
Broken Braunwald-Morrow phenomenon.
Right. So aortic pressure comes from LV pressure increases there. Yeah. What type of apical impulse the patient had? We missed that anyway, I just asked.
Yes, ma'am. Apical usually this is double apical impulse, ma'am.
Your patient has a double apical impulse?
Yes, ma'am. He did have a double apical impulse.
Okay.
How was the JVP, pulse and JVP?
Ma'am, for my patient, JVP was normal, ma'am. And the pulse was jerky pulse, normal in character, volume, no radiofemoral delay, felt equally in all peripheral.
Okay, dear. Okay, that's done. Just go on to the previous slide, Dr. Pavani, please. So what is SAM? What are the grades of SAM? What is the SAM in this patient? What is the grade of SAM in this particular patient?
The grade of SAM in this patient is it was grade 3 SAM, ma'am.
It was grade 3. So what is grade 1, grade 2, grade 3? Quickly.
Grade 1 is there is no contact between interventricular septum and anterior mitral leaflet, and the distance is more than 10 mm. Grade 2 is no contact between anterior mitral leaflet and interventricular septum. The distance is less than 10 mm. And in grade 3 SAM, there is 30% systolic contact between AML, anterior mitral leaflet, and interventricular septum. And in grade 4 SAM, there is more than 30%.
This looks like grade 2, no? Actually, there is no contact. I mean, I feel there is no contact. So, okay, continue. Thickness of the interventricular septum?
What is the IVS thickness?
Ma'am, thickness of the interventricular septum is more than 15 mm.
Is it important to know from management point of view?
Yes, ma'am. It is important to know. We should know.
What is its importance?
Ma'am, if for any procedural interventions, we have to know about septal thickness, ma'am. Especially septal myectomy patients where the gradient is increased and there is great
It's
force.
not myomectomy, it is myectomy.
Myectomy.
Yeah.
Yes, ma'am.
No, what is its importance? Others can also write in the chat box. Is there any cutoff for septal myectomy or alcohol septal reduction?
When the patient is not cannot tolerate, there is refractory symptoms despite taking medical interventions, patient can undergo interventional therapies, ma'am.
No, I was asking about the thickness of the septum and its importance with respect to management.
Okay. Yes.
Okay, what is the present day indication for alcohol septal ablation?
When the patient is in an elderly age group patients, we usually undergo alcohol septal ablations, ma'am.
Yeah, surgically high risk.
Yes, ma'am.
Otherwise, standard of treatment at present is
Myectomy.
myectomy.
The alcohol septal ablation, how will you choose, how will you go in for an alcohol septal ablation? What you will do mandatory before that and during the procedure? How will you select where to inject the alcohol? And how much percentage of alcohol?
Patient selection is based on presence of we have to based on the presence of septal perforators. Major septal perforators are targeting which supplies the septum, and
which investigation will aid you in selecting the target septal?
Contrast echocardiography.
Yeah. Contrast echo. Yes.
Sometimes it may not be a single septal perforator, it could be a double septal perforator. So that is also very important. And what are the complications of alcohol septal ablation? Absolute alcohol, how do you?
A patient can go in for transmural scar formation. This can lead to arrhythmias.
You have to tell the common complication first.
Commonly, what they develop?
Commonly, what problems do we face?
Patient can go
Somebody
in for
has already
arrhythmias.
written.
Complete heart block.
Right bundle branch block, complete heart block, which can be transient or, sometimes they may end up requiring a pacemaker. Yeah, what other complications? The scarring is all later.
Okay.
And transmural scar is all, it's so thick, transmural scar is all, very rare.
So which patients you will avoid doing an alcohol septal ablation?
Patients with the right bundle branch block, we have to avoid alcohol septal ablation.
No. The other way, no?
It's
a patient has
produce RBBB, right?
Yes.
So it will induce RBB. So already a pre-existing LBB you should avoid. Okay, then those are the patients who will definitely develop a complete heart block. The risk is high. Okay. So okay, what is the role of pacemakers in these patients? What type of pacemaker do you prefer?
Dual chamber pacemaker is preferred in these patients, ma'am. It's not a first line treatment. The patients with the risk of sudden cardiac death are preferred for this dual pacemaker interventions.
Not only for that.
And complete patients who go in for complete heart block, risk of complete heart block.
Not only for that, for this LV synchrony, no, for that also it can be used. Okay, but
Okay.
those are rare indications. Another important thing I would like to inform you is that though it is common in the third decade, for children, they may not present with such big thickness. Though it is rare in children, but still you have to see the Z mean score in children. If it is more than 2, then you suspect HOs, obstruction. In children, when you screen, suppose the first degree relatives, the children, so usually they present in the third decade only, but rarely when you look into that, you cannot assess for 15 millimeter thickness in a child. So you have to know the mean Z, the mean
Yes,
Z value, and then more than 2 you have to consider. I think we have Dr. Varun with us with an important presentation. Dr. Abhirami and all the PGs have done a great job. I think we will move on to the presentation, then come back if their time permits. Very good, Dr. Abhirami. And all the postgraduates have done an excellent job. Yeah. I thank my coach, Dr. Nagamani ma'am, who has been excellently firing the PGs. Very good. Very nice, ma'am. Listening to you. Yeah, we will move on to Sir's talk.
Thank you so much for giving me opportunity to present in such a wonderful platform. I was hearing through the discussion and of the case. It was very excellent discussion. Uh, Now I am asked to talk about the recent advances in hypertrophic cardiomyopathy management. I think this we are in an era where we have shifted significantly from the symptomatic management to disease modifying precision medicine, especially in the hypertrophic cardiomyopathy. Um, so these are we have already discussed. There are two phenotypic spectrums. The HCM is usually a spectrum, the obstructive and non-obstructive HCM. So obstructive HCM is usually seen in two-thirds of the cases, and key features are resting or provoked LVOT gradients, which are more than 30 minutes can go up till more than 50. And usually pathophysiology is basal septal hypertrophy coupled up with the systolic anterior motion of the mitral valve. And non-obstructive HCM, which is seen in one-third of the patients. And then it has no significant dynamic downing obstruction, and pathophysiology is usually symptoms are driven by the diastolic dysfunction, impaired myocardial relaxation, and microvascular ischemia. We are refining the diagnostic criteria using the usually most important diagnostic toolkit we have is echo, where LV valve thickness is more, and in children we are using the Z scores to score the LV valve thickness, and also we have to use the provocation like Valsalva to have the LVOT gradient. And most important recent update is the usage of cardiac MRI, where the late gadolinium enhancement more than 15% is a critical threshold for fibrosis burden and risk stratification, and also native T1 mapping, and also the extracellular volume for phenocopy exclusions. So these are the two different assessments we have. One is a path A, where we are using a European ESC guidelines, which is a composite 5-year risk scoring, and also the AHA individual major risk factor assessment scoring. So the annual sudden cardiac death in HCM is estimated around 0.5 to 0.8% in adults. So these are two different philosophies where the primary prevention guidelines clash. So the ESC guidelines, which is score driven, as we already discussed, it is divides it into the low, medium, and high risk, where low risk is less than 4% at 5 years. And the ICD is not recommended unless until you do a cardiac MRA, and the LG is more than 15%, or the patient has LV ejection fraction less than 50%. And the medium risk category, where it is risk is between 4 to 6%, where the ICD comes as a class 2B indication. And the high risk has more than 6%, and ICD becomes a class 2A here. It has a high specificity of 92%. Whereas the AHA 2024 guidelines is a factor driven. So more than or equal to one major risk factors warrants ICD, say the class 2A recommendation, the family history of sudden cardiac death, massive left ventricular hypertrophy more than 30, unexplained syncope, LV aneurysm, and also LVEF less than 50%. It has high sensitivity, around 95%. So the emerging risk assessment is mostly we are all using the advanced cardiac MRI, where LG and also extracellular volume correlates with the more strongly sudden cardiac death than LG alone. And also genetic status, specific mutations like MYPC3 and TNTT and MHC correlate with elevated arrhythmic risk. Even though the polygenetic factors complicated the isolated variant analysis. And also recently the artificial intelligence, especially the FDA approved AI ECG platforms like with HCM achieve almost 95% sensitivity and more than 98% specificity in identifying 5% of the new HCM patients who were previously missed by the clinical detection. So historically, we used to use the standard of care, which has its ceiling. So we used to use the beta blockers still at the first line for HCM, obstructive HCM, which lowers the heart rate and also improves the diastolic dysfunction. And next, the use of the CCBs and also disopyramide, which is not easily available. So this hits a ceiling in the traditional treatment standards. So that now we are in a phase where there is a paradigm shift in the management of HCM. So for decades alone, HCM was managed reactively. Initially, it was a historical approach focusing on the symptom relief and mechanical correction, and non-specific drugs like beta blockers, CCBs, and myectomies. So now we are in a precision era where we are focusing at is disease modification and inhibition of the target. Is we are working at the target level, and we introduction of the cardiac myosin inhibitors and genetic therapy and also minimal invasive ablations give us additional advantage of targeting the sarcomeric hypercontractility directly, and also it also promotes the reverse remodeling. And we are also exploring the true genetic cures for the HCM. The paradigm shift is mainly responsible because of the cardiac myocyte inhibitors. These target the source of the HCM, which is usually the hypercontractility is seen in the HCM, where the sarcomere is hypercontractile and also there is impaired relaxation. Now, because of the cardiac myosin inhibitors, these work at the sarcomere level. So they stabilize the sarcomere at the super relaxed state. Thus, there is reduced LVOT obstruction and also improved energetic metabolism. So the myosin inhibitors directly act at the sarcomere, reducing the actin myosin cross bridges, forming the true disease modifying agents in HCM. So coming to the evidence pipeline in obstructive HCM, we have four important trials, the Explorer HCM trial, Valor HCM trial, where mavacamten demonstrated a significant 77% reduction in need for the septal reduction therapy, and also it showed that it can favorably structurally remodel LV mass and the left atrial volume. And Maple HCM, which is an ongoing therapy, which directly shows that head-to-head evaluation of aficamten versus metoprolol. Whereas Sequoia HCM showed a significant increase in peak oxygen uptake, and also time eligibility of septal reduction therapies has been shortened by 78 days. This again shows the same thing. It shows that the peak oxygen uptake has been significantly affected by using aficamten. Same here, and Maple HCM also shows that this aficamten is superior to the metoprolol monotherapy, especially in change in the peak oxygen uptake. But whereas there is a significant improvement in management of obstructive HCM with invent of the cardiac myosin inhibitors, but non-obstructive HCM still there is a dilemma where Odyssey HCM, where the mavacamten use did not prove they meet any primary endpoints, especially in the quality of life improvement and also peak oxygen utilization. But we are still exploring the newer options like evaluating the cardiac myotrope and metabolic modulator targeting the ventilatory efficiency. This is the Odyssey HCM where there was no significant change in the quality of life. This is the head-to-head comparison between the two myosin inhibitors which we have, mavacamten and aficamten. The half-life is of mavacamten varies between 6 to 23 days, whereas the aficamten has 2.8 days. Dose titration, we have to, mavacamten has to be slowly up titrated over 4 weeks. It can be titrated at 2 weeks. Lesser drug interaction is aficamten. And risk of LVF less than 50% is higher relative risk in mavacamten, whereas lower relative risk in aficamten. And both the drugs have shown very good efficacy in reducing the gradient reduction. Again, most of the things show the same here. It's a direct head-to-head comparison between these two drugs. Coming to the initiation and phase dosing algorithm of mavacamten, we have to start. The patient has LV ejection fraction of more than 55%. We will start at 5 mg once daily. Then at week 4, we'll again reassess by echo. If the Valsalva LVOT gradients are less than 20 or more than 20, if it is less than 20, we can reduce the dose to 2.5, and we can continue the dosing same. If it is more than 20 is there, then we have to increase the dose. We have to upgrade it to 2.5 mg to 5 mg and 5 mg to 10 mg, and 10 can be maximum increase up to 15 mg once daily. So every 4 weeks we have to check echo, and also we have to see two things. One is the gradient and also the LV ejection fraction. If it is coming down to less than 50% and the LV gradients are reduction less than peak Valsalva gradients less than 20. So if it is less than 50, we have to interrupt the treatment. And if it is between 15 to 50 to 55, we can maintain at the same dose and follow up the patient. If the LV ejection fraction is more than 55, we can maintain the same dose if the Valsalva LVOT gradients are less than 20. And if the LV ejection fraction is good and the Valsalva LVOT gradients are still high, we can, as I told, we can follow up the patient every 4 weeks and we can uptitrate the dosage. So, as we all know that there are two established septal reduction therapies. One is surgical myectomy, and also second one is the alcohol septal ablation. So alcohol septal ablation traditionally is performed by catheter-based ethanol injection into septal perforator. But usually it has limitations like 9 to 10% of the patient can have the pacemaker implantation due to conduction disturbances. And these are usually reserved for the patients with severe NYHA class 3 to class 4 symptoms and also LVOT gradients more than 50 despite the optimal medical therapy. So, but one most important factor for this septal reduction therapy, usually these are good outcomes are reserved to the high volume centers where their expertise is there in performing both the alcohol septal ablation and the surgical myomatics. This is the main Achilles heel in giving the septal reduction therapies to HCM patients. I think in India, very few of the HCM patients with symptomatically severe LVOT gradients undergo septal reduction therapies. So there are few next generation intervention techniques which are coming up. One is percutaneous intramyocardial septal radiofrequency ablation, which is through a transapical needle. We use an radiofrequency needle, and then we can ablate through radiofrequency ablation. The septal ablation can be done. One more is the transapical beating heart septal myomectomy, which is a minimally invasive compared to the previous surgical correction. And also septal embolization is being done with the microcoils rather than with the alcohol septal ablation. This minimizes the localized infarct and also eliminates the toxicity and the conduction risks of the alcohol. And coming to the targeting at the genetic level, because the HCM, the genetic level is the most important thing. 30 to 50% of the patients have pathogenic or likely pathogenic variants in genes. It's quite common. It is around 30 to 50. Most commonly, it is around 40%. So clinical genetic testing is now class 1 recommendation, and we have to drive the cascade screening in the family members and identify the candidates for the future allelic specific therapies. This should be our primary concern now. And the primary culprits are, we already discussed MYBPC3 and MYH7, which account for almost 70 to 80% of the genotype positive cases. So the genetic therapy frontier includes the genetic replacement by adding these uses the adenovirus associated vectors which deliver the functional gene copy, so that the loss of function variants can be treated. And also genetic editing, that is fixing by CAS9 base editors directly these pathogenic variants at the DNA level can be corrected. This can be applied in the missense mutations like MYH7, where the correction has been seen successful in more than 70% in the preclinical models. And the genetic silencing, especially by using siRNA where it selectively binds the mutant mRNA there and also preserves the expression of the protein. So this is a modern HCM treatment paradigm. So universal symptom control, and then the two is the disease modifying pharmacotherapy. That's because in introduction of the cardiac myosin inhibitors, and also invasive mechanical therapies by advanced septal reduction therapies, and tier 4 is the gene therapy, which is coming up. So era of precision medicine, from phenotype to genotype, and management is shifting from blunt symptom control to targeted intervention based on specific sarcomeric defects. And also we can use the AI and risk predictions, integration of the AI, ECG, and the multimodal imaging like CMRI for the identifying the hidden risks and redefining the primary prevention criteria and SCD stratification. And true disease modification by using the cardiac myosin inhibitors and using the advanced new interventions to give best of the standard care to the HCM patients. Thank you.
So I think it's been a really great session and great time. We had a great talk by Dr. Varun, which summarized everything. And of course, our very esteemed faculty members, Dr. Cicely Magella and Dr. Nagamani, who not just grilled the student, but also delivered several important points for our students to learn and remember. So any comments from the faculty? Though we are 15 minutes ahead, but I was just enjoying listening to the entire talk. Any comments from Dr. Magella, Dr. Nagamani, or any questions to Dr. Varun?
Yeah, Dr. Varun, I had a question. With respect to use of beta blockers, is there any change? Like, earlier we were taught that only non-vasodilating beta blockers are recommended. But recently I have come across reports where bisoprolol is being used for treating HCM. What is your comment on that?
Yeah, ma'am. I think that's a big thing. And also the challenges come when we are using the hypertension. We are treating the hypertension in HCM as well. These are the usual questions we get whenever we are treating the hypertension in HCM as well. So I think still it is the metoprolol, which is I think we still need more literature for the introduction of the newer beta blockers. I think maybe we are shifting more from beta blockers to targeted therapies, ma'am. That's what I feel, because more trials which are coming up are challenging the metoprolol as a class 1 drug, and they want to replace these cardiac myosin inhibitors as a initial class 1 drugs.
Yeah, but it's being expensive. There are a lot of limitations in use. Does anybody has a personal experience in using mavacamten?
Yes,
Can anybody
ma'am.
share their experience, please?
Yes, ma'am. Yes, ma'am. I'm one of the principal investigators for mavacamten, and our hospital is approved, and we get free mavacamten from abroad, and it has shown excellent results, ma'am. For these patients, really, we are able to see. Actually, some patients are responders and some patients are normal responders and some are under responding. So we have to assess it. And for one young patient, this patient was very good. He responded very well. The LVOT gradient has dropped from nearly 80 to it has come down less than 20 now. And another patient, he was not responding. So we increased the dosage to 10 milligrams. The dose was increased and he has responded well. Another patient, my private patient, she's responding with even just 2.5 milligrams. So there are, but one important thing is we need to look into the LV function. We have to repeatedly look for the LV function. But since it is given free of cost for us, we have enrolled patients, and I am the PI for this. But the outside patients also, those who are affordable, a huge lot of HOCM patients outside there, and they really do well, ma'am. The incidence of septal ablation, everything, as sir rightly said, it has definitely come down. Before we were referring for surgeries and all those things. Now it has definitely come down. And as mentioned by sir, this newer drug, aficamten, the thing is, it has got a shorter half-life over mavacamten. It is only hardly 3 to 4 hours, and the cytochrome P450 the interaction is with aficamten. So that is an advantage of this newer molecule with mavacamten, so that the drug washout is also very fast. But still, we are with the trials, and there is a chat who has Dr. Bhavana, whether the role of mavacamten in non-obstructive HCM. The trials are going on. We are also part of the mavacamten in non-obstructive HCM, but it hasn't come yet into the guidelines. Definitely in obstruction, it has got a great role. It reduces the gradient. We also assessed MVPO2 levels, and it has shown a significant improvement. But non-obstruction, the trials are going on. It has yet to come into phase 3 and phase 4. We will have to wait for the
already 2
results.
trials, that Maverick
excellent talk by
trial and the
Dr.
other Maple HCM. Both have shown good results
Yes,
in
ma'am.
even in non-obstructive HCM. But when they develop LV dysfunction,
Yes,
you
ma'am. Yes.
withdraw the drug, and once the LV improves after say 4 to 6 weeks, when you reintroduce it, I think they will develop LV dysfunction again, right?
Yes, ma'am. Once LV dysfunction, it comes, it never reintroduce the drug, ma'am. But of course, they say we can reintroduce, but I think it is with the risk, because LV dysfunction in HOCM, there will be a rapid downhill course. We have to watch it.
Yes.
Though they recommend every 4 weeks and all, but I asked them, just they did not pay for in the government sector. It is absolutely free. In private sector, I just one screening of the AEF. It's just we can do it frequently, even because that's an important indicator to withdraw the drug. But I think it was a great talk by Dr. Varun. Thank you so much for accepting an invitation and being with us with all the newer concepts, sir. Thank you so much.
Yeah.
Thank you.
You're
So I think
updated,
it's
Dr. Varun.
been,
It
yeah,
was
very
very
nice.
nice.
It was a great talk, and we enjoyed the session. And it was, not just the drugs that you've brought about, you've also talked about the upcoming genetic therapies and, development of radio frequency ablations and so much more that we can look into the management of HCM. And just like any other disease, these newer drugs will come up and find their way where they have to be, and time shall further unfold the longitudinal, how we remain with this drug, how well we functions remain, and how we further develop. But it was really a great insight, and it has been an amazing day. Is Dr. Soumya, are you there? Do I ask you to conclude the session to thank our
No,
amazing
ma'am, you can
faculty and the
conclude
guest
that.
speaker of the day? Please go ahead, Soumya.
Uh, Thank you again, everybody, for such a wonderful session. Uh, Thank you, Nagmani ma'am, Cicely ma'am, Shiva ma'am, and of course, Jyotsna ma'am for letting us do all this. Thank you, Varun. Again, in the last minute, you did a great job. And there are almost like 45 participants today. I'm sure that we should reach more and do more and more good work like this. Thank you, everybody. That was a great session today.
45 participants and 15 faculty, including the PGs
Oh,
present. So
Yeah,
it is all,
and
it's
nice
abundant
one.
thanks
happy.
to
That's a huge number.
Medgamy also for supporting us, yeah, in our endeavors.
Yeah.
Thank you, Medgamy, for, yeah. Thank you, one
And
and
Dr.
all.